Good morning and welcome to the 2024 Local Public Health Forum. It celebrates Public Health Week, National Public Health Week, April 1st through 6th, and part of programs of the Public Health Museum in collaboration with the Massachusetts Health Officers Association, the Massachusetts Environmental Health Association, the Massachusetts Association of Health Boards, and the Massachusetts Association of Public Health Nurses. And this morning, the topic is housing and housing stability, a very hot topic now. I think from a public health standpoint, a welcome hot topic, and in the long-term understanding that housing is a critical social determinant of health. Without further ado, I'm going to turn it over to Harold Cox, professor of practice and community health sciences at the Boston University School of Public Health and longtime local public health leader, former chief public health officer in Cambridge, as well as a member of the Massachusetts Public Health Council, and former member of the Boston Public Health Commission, and our moderator for this morning, Harold.
Al, thank you very much. I'm so very glad that the museum and that the public health organizations have chosen this particular topic to address. Our state has a major housing problem. Some would say we have a crisis. And today's conversation is about how to discuss housing problem, and it talked about the impact that the housing problems has on public health, as well as in particular on local public health departments that are part of addressing the issues. When we talk about housing, it's important for us to understand that there are many populations that are impacted. There are individuals, there are families, there are those who are chronically unhoused, there are new people that become unhoused because of losing a job or mental health concerns or a variety of other kinds of things. There are individuals who are new immigrants to our state who are trying to get situated here, as well as there are many people who live in our state who are just looking for affordable housing. This crisis affects each one of these groups and so many others very differently, and it poses some very unique public health challenges for all of us. It's important to understand that one solution does not fit all, and that it's important for us to understand the various populations and the various ways that we need to address the needs of those individuals. We unpack these things that I've just mentioned, and our panelists will look primarily at talking about three things. One, we're going to try to understand what are the problems we're dealing with. Number two, we're going to talk about what are some of the solutions that we're currently looking at and doing. And number three, we're going to talk about, well, what's missing? What else is it that we should be doing? So I'm glad that you're here. I'm glad that they're there, and we're going to kick this off. I'm going to also ask you as participants to be active participants. And that means please share with us your thoughts in the chat or in the Q&A so that we know what you're thinking. And then later into our conversation, we're going to promote all of you into the stage so that you can engage with us in a more interactive kind of way. But I want to start first with our panelists, and to help you know who our panelists are and to get a sense of the problem, which is where I want to start first, is what are we talking about? I'm going to ask each of our panelists to tell us who they are, where they work, and then from their perspective, how do they define the housing crisis that we are experiencing? I'm very glad that Commissioner Robert Goldstein is able to join us, and I'm going to ask the Commissioner to kick off this conversation.
Thank you so much. And it's great to be with everyone today and to celebrate Public Health Week. So as folks heard, I'm Robbie Goldstein. I'm the commissioner at the Department of Public Health. And just by way of a little bit of my background, prior to my time at the Department of Public Health, I spent 2 years at the Centers for Disease Control and Prevention at the federal level, thinking about public health as a senior policy advisor, working with the director. And before that, I was a clinician at Mass General Hospital, working both in the infectious disease space as a primary care physician for people living with HIV and at risk for HIV, and as the medical director of the transgender health program at MGH. I would say it's my clinical experience that really informed my perspective on housing and the importance of housing in health and in public health. I firmly believe that housing is a human right, and it is part of a very critical part of the social determinants of health, and that we in government and in public health need to support housing development, keeping people in safe and healthy houses. And I think we are here because in many ways, we as a society have failed in this effort. If we look at data from the Department of Public Health, from our Community Health Equity Initiative and our recent survey that was completed, 20% of adults in the Commonwealth report that they are having trouble paying for their housing. That is 1 in 5 adults in Massachusetts cannot afford to live where they are living right now. And we know that having a place to live, having a safe home, promotes good physical and mental health. Right? We need to make sure that people have a roof over their head and that where they are living also provides them a safe and healthy environment. I think we need to be clear, and we'll, I think, go through this in the conversation today, that housing is not the magic bullet. It is not going to solve all of our public health and health needs, but it is a very critical component to making sure that people can address the issues that are going on in their life and can prioritize other health needs that they might have. So I'm really excited for this conversation. I want to make sure that others have a chance to introduce themselves and explain their perspective and where they're coming from, and then we'll dive into the discussion.
Thank you very much. I'm just going to take you in the order that I see you on my page. Regina.
Hi, thank you, Dr. Cox. My name is Regina Hansen. I'm an assistant director at the Housing Inspections Division for the City of Boston's Inspectional Services Department, a position I've been in for 27 years here. I reiterate a lot of what Commissioner Goldstein has said, and I do believe that housing issue is a societal failure. We have not kept up with the changes within society. We have not kept up with the movement of people in society, and also listening to the community, what their needs are, what their wants are, so that they can have a safe place to stay. You know, I go back to my 5th grade humanities teacher, Mr. C, God rest his soul. And one of the things he always reiterated with us is the 3 basic human needs are food, clothing, and shelter. Shelter is a social determinant of health. It's a gateway to other services. I think we need to step up our efforts to make sure people, anyone in Massachusetts or in the nation, has a safe place to stay at night. Thank you.
Thank you. Cheryl. I'm sorry, you're muted. Cheryl, you're muted.
Hi,
Yeah.
I'm all set now. Good morning, everyone. I am Cheryl Sabara. I am the Executive Director and Senior Staff Attorney for the Massachusetts Association of Health Boards. And as all of you know, our local boards of health have a great deal of legal authority to enact local public health regulations. And I have been working for the past almost 30 years in local public health. And I'm going to talk about 2 things that I am thinking about when I think about this critical topic. And the first is what the commissioner said and what Regina is underscoring. I think there is a human right to safe housing. And one of the things that local health departments are charged with is making sure that these homes are safe. I've seen too many examples of health departments doing inspections in homes that are not safe, that are unsafe, that violate the housing code in so many different ways that it's almost inexplicable. So safe housing is a really important piece of the housing crisis that we have. The second thing I want to mention is the housing crisis when it comes to people who use drugs. And as many of you know, we now are in receipt of funds from, at the time, Attorney General Healy's lawsuits against the drug manufacturers, distributors, and pharmacies for the harm they caused in basically trying to hoodwink both physicians and those folks that needed pain medicine and ended up addicted to opioids. And they're paying for that with their dollars now. And when you talk to people who use drugs, which I have done in various settings, one of the issues that comes home to them time and time again when they're looking at priorities is having a place to sleep at night without all of these sober requirements and issues that they can't deal with right now. They need clean syringes and they need a place to live and a place to sleep, especially. And if they don't have those things, we're not doing our job when it comes to harm reduction. So we forget a lot about that group of folks. We clearly have lots of stakeholders in the game here, and we have a lot of people who really need our help in finding housing that is safe. And I'll pass it back to Harold.
Thank you very much, Cheryl. Sarah.
Hello, I'm Sarah Harris. I'm the Deputy Chief of Public Health Nursing for the City of Worcester. I'm also the Vice President of the Massachusetts Association of Public Health Nurses. I am fairly new to the central part of Massachusetts. A lot of my public health background is more focused in the Boston area and Somerville and in Medford. But now being in Worcester, it has actually opened my eyes a little bit differently to the housing crisis, whether it was, I saw it a little bit in the Boston area before I came out this way to Worcester, but seeing these big high rises pop up right in the middle of the city and displacing a lot of the population in which Cheryl was just speaking, coming from an outsider into the community I now work in. So I'm happy to say that that is a priority that we have here in this city. And we have done a lot, or we've done some, I shouldn't say, we've done some, and we know that there's a lot of progress to be made, but we've partnered up with great organizations, part of this panel today, as well as community groups, and really just learning and figuring out what it is that people need and how we as people at the different levels of advocacy we are at can do to help them achieve that goal. So as many of you mentioned, housing is, especially for me as a nurse, one of the basic human rights like food and clothing. So it's definitely something that I'm extremely passionate about. So thank you, Harold. Back to
Thank you, Sarah. Dr. Gabo.
Good morning, everyone. Such a pleasure to be with you. Dr. Gabo with IFSI, Immigrant Family Services Institute. And I'm coming to this conversation with probably two different hats than anyone else. First, I am a public health professional and work around maternal and child care for a long period of time. And also I'm a community leader. So I bring those two together. And because our organization IFSI has been working mainly with the new arrivals, our new neighbors who have been with us for the past 2 years. And my kind of perspective is not so much around people who are here and we need access. It's mainly about the double or the added burden on new arrivals who are here for the first time and do not know the community, do not understand the system, and so often find themselves, everywhere everywhere that you can think or imagine, hospital, school, community, trying to understand what to do, where to go, and how to go about where am I going to sleep tonight. So this is really what we call a public health crisis, because we know, as Commissioner Goldstein already said, is that when you don't know where you're going to sleep and you have a baby with you, the level of stress the level of, challenges that you have to deal with really added all the way to the roof. And we are already talking to nurses and medical doctors saying that they are seeing more and more trauma, more and more families coming with other, health conditions that they didn't have before. And again, it's because of, this not knowing where am I going to sleep tonight. So I think it's a really important topic for us to discuss, especially around the new arrival, because we know that Massachusetts already had a housing crisis. Now those, this influx of people coming, it's added here for us to brainstorm about what we can do to make sure that we can support those families who are here in our midst and need us. All right, thank you so much.
Thank you very much. Tyler.
I think that's a perfect setup, Dr. Gabo. Thank you so much. I'm Tyler Newhall. I'm the Director of Municipal Relations for the Executive Office of Housing and Livable Communities, which oversees the shelter, the family shelter program, the emergency assistance program, as we call it. And also I serve as the legislative director for the cross-agency incident command structure that's responding to the shelter crisis in Massachusetts. So I really come at this with a lens of families in shelter, and am excuse me a second. Can you all hear me?
We can.
Yep.
We can hear you.
Okay. All right. Sorry, my computer froze for a moment there. So I really come at this from the lens of families in shelter, and keeping in mind that Massachusetts is the only right to shelter state in the country. There are a couple of cities and other smaller enclaves that have a right to shelter. But we are the only state with the right to shelter, and we've seen a growth in our shelter system of new arrivals, as Dr. Gabo has alluded to, where our shelter system has tripled in the last 2 years. And in April of 2022, we had single-digit number of families in hotels. Now we have thousands of families in hotels across the state, many of whom are supported by a shelter provider, one of our shelter service providers, many of whom are not and have been in unstaffed shelter sites, and really have leaned on the community, in many cases the local board of health and local public health directors, to provide a lot of the services and healthcare in particular to families. I think the last point I'll just make is I've really seen over the last 2 years how shelter shapes the way in which families live their lives, and how every single decision we make and really every aspect of the family's lives is connected to their health and well-being, from, as some mentioned, the safety and security of families in our shelter buildings for things like mold and structural issues, all the way to, how do we respond when there is a family that has an emergent health need, and things like nutrition, and there's so many ways in which we need to be aware of families' health needs as we try to provide them the best possible service that we can. So I look forward to this discussion, and thank you all so much for being here with us, and happy Public Health Week.
Thank you. Natasha.
Hi, good morning, everybody. Thank you so much. It is such a pleasure to be part of this panel with so many wonderful professionals that are doing such great work. And I want to echo what my colleagues are saying. I am the health director here in Arlington. And so the perspective that I'd like to bring to the discussion today is really, sort of about how public health at the local level has changed. And, the regular day-to-day mandates that local health departments have, such as enforcing the state sanitary code, have been, they have become so complex because the issues that we're going out, it's no longer going out to a home to inspect and just ensure that it's safe and sanitary for those who are living there. There are so many complexities in terms of mental health components, access to basic needs, to food, to being able to pay for their rent, being on the verge of homelessness. And I think, from my perspective, what has worked well and what has we've tried to do in our community is really try and come together with lots of different departments and agencies that are providing these services to discuss these issues. And in some ways, we've got this built-in referral system so that, when we're out doing those housing inspections and we notice that there may be some other issues associated with that, we can bring it to our groups. We have a group called the Human Services Network in our community, and bringing it to that group and being able to discuss some of these issues is a natural way to connect these folks to other services. Now, it is not a full, proof, approach. It doesn't guarantee any housing or address those issues. But in some ways, what we've been able to do is really lean on our partners in different ways. When we had newcomer families that had arrived in our community, we were able to pull together this core group and ensure that those folks had the basic needs that they needed. We had social workers that were able to come to the table and ensure that these folks were signed up for Mass Health or reach out to our food pantry because we already had these existing relationships. And so that's sort of the perspective that I'd like to kind of bring to the group today and talk about, and just how important the role of local public health is, and to recognize that not every community has the same staffing, has the same structure, and that is really, really challenging. And the more that we can lean on, one another and our colleagues' practices is really what I'd like to just talk more about today. So thank you again for the honor of being here, and I look forward to our discussion.
Natasha, thank you very much. And I actually want to build now on the things that you've actually just been talking about as we talk about, so what are some examples of how homelessness or dealing with unaffordable housing leads to health problems in our community? As I was listening to you, I heard a number of themes. All of you said something about rights. You talked about how important housing is, and you also talked about how complex it is as well. So in that context, it becomes really important for us to kind of delve a little deeper. And I want to kind of think a little more. So can you think about some examples that help us to really understand the specifics of what you...
Yeah,
Yeah,
earthquake.
please. I have a person. Are we?
Earthquake.
Okay, there he is. All right. My house is just shaking like crazy right now.
The floor is shaking like crazy. Everything's creaking.
Yeah. Okay. So I think I'm okay. If things start falling in on me, I'll let you know I'm not all right. But at this moment, I actually would like to actually delve a little deeper into what you're talking about and help us to understand. Do you have some specific examples you might be able to share with us? Anyone?
You mean example in terms of how housing is
Yeah, about how homelessness or unaffordable housing leads to health problems in our community. I'm just kind of interested in, we've talked very broadly about this. I want to just bring it home a little more because it becomes clearer to people when you start talking about, here's what happened to a person. Here's what's actually happening.
Yes. So I can quickly start with if anyone who is following the news around since 2021, when families started to come here and did not have a place to go. The only place that they had as a reference was the hospitals. So Boston Medical Center, for example, became the place where families will come, and spend time. And we were dealing with a number of pregnant women at this time who were coming. Here they are at Boston Medical Center delivering their babies, and 2 weeks later, still in the hospital, and they deliver healthy babies, still in the hospital because they don't have a place to stay. And at some point, the leadership team of the hospital had to make a decision. Are we sending, this pregnant woman with the baby at a shelter, a hotel, or where can we send, that pregnant woman? So just think about here you are being pregnant, delivering a wonderful baby, wanting to be with that baby, and because you don't have a place to go, you have to stay at the hospital, or maybe, just praying for some kind of divine intervention. So think about what happened after you deliver the baby, the risk of you, developing all type of traumatic experience, and even for the baby, not having, like a crib, not having any of these things. So those are really putting a lot of stress on families, creating more issues than necessary. So just one example of what has been going on for the past 2 years.
Yeah, thank you very much. That's a really clear, very specific area. Sarah, I saw your hand.
One major part of what I do and what a lot of the public health nurses do here in Massachusetts is what we call direct observation therapy. So we track and follow people who are diagnosed with tuberculosis here in the state. And what I've seen a lot is overcrowding in houses because not being able to afford whatever the rent may be throughout the state. So you have multiple family units living within one apartment. And then when I come into a household and we know, a family is a husband, a wife, and a couple of children, and you get into a household and realize there's other families living in it, you may not know what diseases are being spread, because when we ask who's in your family, we're just told of the immediate families. So sometimes when we're asking questions to people as a group, who's living within your household? And I know a lot of people throughout COVID saw, as numbers kind of started rolling in, you had 3 people at an address, sometimes over 20 people at an address. So I think looking at how the overcrowding within apartments are, because we definitely see in these larger cities, family units living in 1 bedroom of a 3-bedroom, 4-bedroom household.
Yeah, thank you very much. It's really clear as we start thinking about, so sometimes we only think about individuals who are in shelters, but there are many people who are couch surfing that you don't see all the time, and that we don't have a really clear sense about who they are, and the problem gets to be much larger than we can imagine. Regina.
Thanks. I just want to bring up that I've noticed in Boston over the last, I'll say, 5 to 7 years, our number of complaints have gone down for people requesting housing inspections, because I feel that a lot of the property people who do have an apartment are very afraid that if they call in a complaint, their property owner will evict them. They'll have no place else to go. They'll put up with some pretty nasty living situation just so that they know that they still had someplace to go. The rise of the illegal rooming house, where people will take advantage of someone who's in despair, give them a room in a basement next to the furnace. It's not a very healthy situation, but that's what the person can afford. And we see it all the time. People who, are they need someplace, so they'll take whatever is offered, even if it's not the most healthful situation.
It's unfortunate that happens, and certainly it's interesting that your numbers are actually going down as people are trying to protect their place that they have to live. Yeah, Dr. Goldstein.
I want to just bring in one other population too, if we're thinking about specifics of areas where we see the housing crisis impacting health, and that's the elderly population. And I've traveled across the state, and it doesn't matter where I am, whether it's in the Cape, in the Merrimack Valley, out in Berkshire County. Seniors are really struggling right now. Many are in homes that they can no longer care for, but they can't afford to move into another facility. They aren't, and they shouldn't be going to skilled nursing facilities because they don't need that level of care. What they need is safe, supportive, healthy housing that is scaled to the right size for them to live in and be healthy. I'm really worried about our elders across the state, that they just do not have resources to get into these places. And we are risking their health by keeping them in big old homes that they can't care for, or risking putting them into an institutionalized system that we know the evidence does not support. So it's a population that keeps me up. It makes me think about what else we need to do in the housing space.
This is broad. We talked about a bunch of different populations that are in need, as well as a number of different kinds of situations that are complicated as well. I want to think about health departments now, given that many of the people who are participating in our conversation are from health departments. And I'm wondering what health departments can do to help people who are experiencing housing instability or the kinds of housing initiatives and housing problems that you have identified. Cheryl.
This just reminded me of a book I read a while ago called Rough Sleepers. I don't know if any of you are familiar with that book, but it was written by Tracy Kidder, and it follows Dr. Jim O'Connell's work with the unhoused in Boston. And it's a eye-opening book on the culture of the folks that are homeless in Boston. I know that's not exactly what you were asking, Harold, but I think it would behoove all of us to to really read that book and see how they live and what the public health needs are for these folks and how difficult and challenging it is to give them what they really need. And I would also just underscore what the commissioner just said, having a 91-year-old mother myself, and looking at the options that are available for someone who cannot do any of the activities of daily living, and what the choices are for them. And it's disheartening, and it is also, I think, a real scar upon our local public health system, and not just in Massachusetts, but across the country, that, we can't even care for those folks who, have lived on this earth and contributed so much to our country, but they get to be 80, 90 and infirmed, and there are no options that are affordable for them.
Yeah. Cheryl, thank you very much for calling attention to Rough Sleeper. I want to echo what Cheryl has just mentioned. Please read that book. It's sobering in thinking about the problems of the population, but it is also an incredibly wonderful ode to Dr. Jim O'Connell and the incredible work that we all know that Jim is doing. So it's called Rough Sleeper, and it's by Tracy Kidder. Natasha.
Thank you so much.
Before you speak, I just see the note that the earthquake that I felt was real. So, okay,
Oh, yeah.
Yeah. Natasha.
I did not feel that. And so I had no idea what was going on, but thank you for letting us know, because I didn't know what was happening. So thank you. I would just like to talk a little bit about bringing this to the sort of local level. And I think that this is a great segue into the importance of health and human services models across the state. I think I'm starting to see a lot more local health departments taking on this role of health and human services, and it's really not a traditional. I guess when you think about what Massachusetts is, it's the health department is doing their thing and they're focusing on their pieces, and sometimes we get caught up in we're mandated to do X, Y, and Z. And so when I think about the state sanitary code, it's not exactly as cut and dry as going in and citing some violations. What we have tried to do in our community is really take this more humanistic approach in going in and really evaluating what the crux of the issue might be going on. We use this with hoarding, for example. Some of these older folks are in these homes, as it's been alluded to, and they can't maintain them, and they're starting to collect things, and it's becoming unsanitary, and they can't get upstairs, they can't get downstairs. There's little goat paths, and I think one of the things that we really try to do is work with our folks, our community members, in keeping them in their homes as much as we possibly can, and rather than going down the road of a condemnation, really trying to look at what are ways we can keep these folks in their homes, but also ensure that it is safe for them as well as the general public and any first responders that are going in. And I think that that's that human services sort of approach when we know that we're encountering a situation where it might be an elder. We're bringing in sort of our council on aging to help assess, what additional services or programs might be available in our community. Or, we are realizing that this individual may be, financially insecure. We are aware of some programs in our community that might be applicable to these folks. Are they connected with the benefits or the services that maybe they're entitled to? We've got a fuel assistance program in our town that's also through the state, but also a local level one. So having these different little pots of money and opportunities for folks to continue to make it more affordable. And it's not a one size fits all. We do this with sort of veteran services. We have a youth counseling center in our community. We do this with folks who are under the age of 60 years old that don't fall in that. There's a huge gap in that regard. But I do think that it's sort of, as I had mentioned before, taking a look at what our community resources are and making sure these folks are it's a warm handoff to those services. And it's not a one size fits all. It's not going to fix every situation and ensure that there's healthcare for all or access to affordable housing, but it is one step in the right direction to try and ensure that this individual is not just floundering. That when we are going out there, not if an elder goes over to pay their taxes and they can't afford it, that the assessor's office or the collector's office knows that, what, we have a health and human services department and they've been working on some of these issues. Let's get that person over there so that they can get connected to the right resources. And so I think that's something that we've really been trying to do, but I know that it is not something that every community can do. But it is, I think, feeling much more that our local health departments we're being stretched. And we can't, it's no longer just about, enforcing our food codes or enforcing a public health nuisance issue or just the state sanitary code. These issues are so much more complex and we need to come at them with different ways of sort of connecting folks to services. And I think that it feels really good as, a public health director to be able to do those things as well, because it's not just the code is the housing code is very black and white. There's a hole and it needs to be fixed and you're responsible for it. It's diving a little bit deeper and trying to understand what those complexities are. So,
Natasha, I really appreciate where you were taking our conversation. I want to see where Sarah, Regina, and Cheryl are. But you've begun to talk about some of the issues around, so what do you do about it? And what are some of the things that we've got in place? It's important, and it's important especially because Commissioner Goldstein is here. And as he has continued to go out in the state and hear about what's happening, I'm glad that this is also a place where he can hear from the folks on the ground about what's actually happening and what some of the challenges are. So I encourage you to continue to share those things, especially not only for our benefit, but for Dr. Goldstein's benefit as well. Sarah.
To continue what Natasha was saying and go in the direction that you just mentioned, here in Worcester, we have a very similar sort of model like you do in Arlington called the Hub. So we have all the different community partners, elder services, DCF, partners from not only the public schools, but the universities and colleges around here to just sort of, what is it that you all offer? Here are our highest risk cases. How can you be of assistance? Because like Natasha mentioned, we do sort of have constraints, whether it's money from the state, money from here, there, wherever municipalities get it. There is limitations on how we can use it. But when you reach out to those nonprofits and community partners, you're sometimes able to have a little bit more wiggle room and get a family a gas card if, they need to get from point A to point B, or get, whatever. I see you all nodding your heads. Other, little commonalities that unfortunately we know are needed on the municipal level, but our hands are just so restrained with where our funding's coming from that we just can't accomplish it. So I think if you have the capabilities to at least just go out and see what is being offered in those nonprofits in your communities, you all have a very similar goal in mind, which is helping your community as a whole. So just see what it is that they offer, what you offer as a municipality or wherever you may come from, and where you can kind of join forces, I think is where you should definitely start.
Sarah, thank you very much for that, because I think it's important in understanding what the services are. It's kicking off a question in my mind around how we think about working with specific populations. And Dr. Gabot, I'm going to come back to you in a few moments as we kind of talk about that, because I can see the wheels turning in your head and you're going to say, don't forget everybody. So Regina, let's go to you next.
Harold, I just wanted to reiterate what Natasha was saying regarding the local health department really being stretched thin. There are so many different regulations that have come up for the locals to enforce in the time of my career. But, you know, the strict adherence to enforcement really takes away what I think we need to do in public health, which is expand to include, you know, not just knowing the regulations, but being able to spot those instances of human services where we need to step up and be that gateway to services for another person. There's a lot on the local health plate, and there's not enough hours in the day. So really, it's something, not to go too far into the solutions, but also investing in public health at the local level is extremely important.
Regina, you should know that there are probably a lot of people who are watching this and listening to this conversation who are nodding their heads and saying, yes, that is absolutely true. Cheryl.
I'm going to start by saying something that I'm not sure everyone realizes, but we have every resident in Massachusetts has a constitutional right to clean air and water. And it's nothing, we don't talk about that enough, that these are human rights that we're talking about. And in listening to Arlington, Boston, Worcester, these municipalities have the ability to provide some of these wraparound services that we wish were available in every city and town, and they're not. They're not available in every city or town. It really depends upon if you're lucky enough to live in Arlington, Boston, or Worcester, you have those services available. They may not be as resourced as we need them to be, but at least they're there in some way, shape, or form. You go to some cities in this state, I'm thinking about one where a family was evicted because of housing code violations. We as boards of health are about compliance, not about punishment. You don't evict someone because there's a hole in the wall. You just don't do that. But if we don't have workforce standards, performance standards, resources, training for public health staff, if we don't have that basic core training and standards in place in Massachusetts system-wide, then you're going to have these discrepancies forever and ever and ever. And I know I'm putting my advocacy hat on now, but we need SAVE 2.0 to pass so that people throughout Massachusetts have the opportunity that those in Arlington and Boston and Worcester have. And I'll be quiet. But
so Cheryl, you and I know what that is, and I'm certain that some know, but would you explain a little further for those that may not have that?
This is a bill that has been refiled. It was filed when Governor Baker was in office, and it passed unanimously through the House and the Senate, unanimously. And it's a bill that would provide the resources and basically codify the blueprint for public health excellence that was published as a result of the special commission that was created on local and regional health and on the system that we have in Massachusetts that is truly broken. And this bill would actually codify that, put it into law so that we would have the resources that we need to develop a system that is equitable and uniform, and that really looks at equity, efficiency, and effectiveness for local public health. And that's what we need in Massachusetts if we really care about attacking systemic racism and inequality in our local public health system. We need to fund it, and we need to make sure that wherever you live, you have the opportunity for these wraparound services and a lot of other services. So it is right now, we're waiting. It's been reported out favorably. We're waiting for the speaker to bring it to the floor. We feel we have the support for it. And it's critical. I mean, without it, we'll keep going down this fractured road with fractured local public health services.
Cheryl, you've been a champion of this for a long time, so
For
kudos to
about
you.
20 years, as long as you have, Harold.
Well, but we were both wearing diapers at that time.
Exactly.
But, so I appreciate you talking about it and talking about the importance of this. But I want to circle back a moment, because as we were talking about services that are being put in place, and Ty, I'm going to come to you in just a sec, because I want to understand more about the shelter system that we have in our community. But as you were talking about having services put in place, one of the things that Dr. Gabot has reminded us in our pre-conversations is that not all populations need exactly the same thing, and that we need to actually acknowledge that and understand that. And Dr. Gabot, I saw you nodding your head. I saw you grimacing and then nodding your head. So I'm wondering what you were thinking as you were listening to that.
No, definitely. Again, as we discussed earlier, so this crisis that we are in has, brings different groups of people with different background, and that we need with different needs, and that we need to be aware of, who are we talking about? Because I always say there is there is no such thing that one size fit all, because so often we try to bring, as long as we know it's housing crisis, people need a place, so we just try to bring just one model for everyone, when in fact, it's not necessarily the case. So I was just thinking when this conversation was happening about the families that we have coming directly, for example, from the border with children in a hotel, for example, or in a shelter. And food is part of our identity, as immigrants. So whatever we do, we celebrate with food, we cry with food, we mourn. I mean, we do everything with food. So it's part of our cultural identity. So when we are in a place, for example, where we cannot access our cultural, food, we are basically, getting sick. Because again, thinking about public health, right? Thinking about a mom who is trying to feed the baby and does not have access to anything to cook, and has to rely on outside providers to bring the food that they don't eat, they don't know about this food. So thinking about the stress that this can cause families. So again, we always say that it's not a one size fit all. We need to understand the characteristics of the group, and also, and I think one of the things that I heard all of you talking about is that notion of coordinating services. So often services are being delivered in siloed, like this group come and does that, this group come and does that, but there is no such thing as one kind of, a coordinated approach to the service, so that everyone complement each other. So we are not, replicating the same thing. We are not wasting resources, but we are coming with the different areas so that we can serve people. So that's one of the reasons why I always think we've made a lot of mistakes as we are dealing with this crisis. However, we can learn from those mistakes and do better. And that's where I basically personally have issues, is that when we make mistakes, and then we keep on repeating the same mistakes. So that's where the challenge is. But I think we need to learn from all of those mistakes from the past 2 years and see, okay, what can we do better? Which is part of the conversation that I know that you will bring a little bit later, Harold.
Thank you. All right, so let's see where we are in this conversation. So we've talked a lot about, so what's the problem? And we've acknowledged that there is a human right to housing. We've talked about the fact that it is very complex. We've begun to say that health departments are under-resourced, but that they are one of the places that are important in helping to provide care, and needing both in terms of identifying problems as well as actually putting things in place. Some health departments are able to have more extensive services, others are not, and that there is a need for us to have some standardized systems across our state. And so we're looking at this issue around what now exists and what are the services. And certainly one of the important things is thinking about our shelters. And Ty, I wonder if you can give us an overview about the work that you are responsible for in helping us to understand, so what is the shelter system in our state?
Sure. So our shelter system has really changed a lot in the last 2 years, and quite frankly, it's changed a lot since its inception decades ago when the right to shelter was put in place in the 80s, I believe. And it is right now, I would say, it has always been a model of supporting short-term transitional housing for families who are going through a tough time or are experiencing systemic issues that have led to them being homeless, but helping them to get back on their feet, get some access to basic services, and get them through a process of case management housing and transition into permanent housing. In the last 2 years, it's really become a model of, and this is, I say this without necessarily the technical expertise to assert so, but it's become long-term supportive housing for families that have a significant number of needs, many of whom are coming to the country for the first time, haven't had much experience with the American system of healthcare or public school, or just generally don't have a lay of the land of what it is they're walking into. And we are, in a lot of ways, having to provide, pretty much all of the supportive services that a family needs in order to, excuse me one moment, sorry. I don't know if you could hear the pinging on my computer, but I was getting some pinging. I apologize. So I think the approach to shelter has had to become significantly more holistic over the last 2 years. And that's everything from, as it relates to health, Dr. Bo mentioned nutrition, providing culturally competent meals that have substantial nutrition for families, and also recognizing that families have individuals that have different nutritional and health needs, young children, making sure there's formula available and things like that during a shortage. So I think that the approach to shelter has taken on a significantly wider scope, and have really seen the ways in which where you are housed and the way that you interact with the community it determines everything in your life. And from I meet with probably 10 to 20 municipalities on a weekly basis, simply to coordinate services that are in shelters that we don't have an on-site service provider staffing agency, which has been a consequence of the rapid growth of the shelter system. And just I've seen, public health directors across the state, some of the busiest and most stretched from a resource perspective, but also some of the most willing, probably the most willing to step up and say, we will support these families in the absence of a staffing agency. So I work with a number of public health directors across the state on a weekly basis to coordinate things like vaccinations and to coordinate, any emergent health needs, and also to make sure that families that are at shelters have a basic understanding of healthcare and what to do in the event of an emergent health need, and also what not to do necessarily. If your child has a fever, maybe you don't need to call 911. Maybe we can give it a day and we can get you in touch with a primary care physician. So the healthcare piece of shelter has been one of the most difficult to figure out because of the complexity, because of the logistics needed in order to get families to and from appointments. And oh, you need, if you're transporting a child, we need to get we need car seats, and we need to make sure families are safe in getting places. So it has been a significant logistical challenge, but one that we are, I think, getting a better grasp on, and really do appreciate the work of a number of your public health colleagues from across the state who have been some of the most important people for sites across the Commonwealth. So a lot of changes recently, and like Dr. Gabo said, we certainly have made a lot of mistakes in the last 2 years. And we certainly had places in which the shelter system was not equipped and still isn't equipped to respond to the needs of families in crisis situations, but always looking to learn and do better and provide a better level of service that is, equitable and far reaching in terms of where families are sheltered and what their needs are.
I appreciate you helping us understand that, and I appreciate you also giving a shout out to many of our colleagues who are stretched thin already, but doing even more. This brings me to the third part of our conversation. So we've started by saying there's a problem, there's a serious problem. We've said, secondly, that there are some things in place, more are needed. Some have continued to grow, and some have been challenged, but that we do have some things that are actually in place. But we obviously haven't fixed the problem. So I want to move to this next piece of our conversation and thinking about, so what do we need to do? What's missing? What have we not done? What are those missing things from our conversation or from our actions? And I want to invite those of you who are listening also to, again, share with us or with the chat. And in a few moments, I'm going to ask Al if he will promote all of you into this room so that we can see you and so that we can have a conversation with you as well. So please be thinking about those things that you would like to share, either your insights or your or questions that you have for our panelists as well. But help me, panel, in thinking about what's missing from the conversation and where is it that we need to go. So let me help frame that a little more. Let's start first with this idea around collaboration. I've heard several of you talk about the importance of doing collaborative work together. How effective are we in collaborating together? Dr. Goldstein.
I'm happy to start, and I'm going to use a specific example around collaboration where that we can do, and I'm not going to say that we're not doing it well. I'm just saying we should do it better, which is specifically, and Cheryl, you brought this up at the beginning, around housing for people with substance use disorder. And we as a state have invested in low threshold housing for people across the state, and we put a lot of money into this. And I think we've had some limited success. We've had over 450 people that we've housed in low threshold housing. We're doing it at a relatively low cost to the Commonwealth. It's about $40,000 per year per person to keep them in housing, which is, I think, a pretty reasonable cost to do it. But we have hundreds of people with substance use disorder who are experiencing homelessness right now, and housing is critical for them to get into recovery. And where I see collaboration being really important is if we think about the opioid abatement funds or the opioid recovery and remediation funds, the large settlement that's coming into the state, a huge amount of that funding is going to municipalities. And municipalities could together. They could come across either our shared service agreements that we've set up through the Department of Public Health or whatever arrangement they want with their opioid funds and invest that money in low threshold housing. And collaboratively, communities could build dozens of units for people with substance use disorder and give people a step towards recovery that they have not had for a very long time. So it's one of those things where I do think we're doing this. I think we're trying really hard, but there's a lot of collaboration that could work in our favor to get more people housed.
Thank you very much. Clearly an important population to look at, and certainly an interesting way to think about collaboration. Regina.
I had two things to bring up regarding collaboration. To build on what Dr. Goldstein had just brought up, in this epidemic of the disease of despair, in Boston, we have about 200 low threshold shelter beds. And, just real quickly, there's a survey that about a little more than 600 people have gone through those beds in the last few years. And they do a survey at the end. And I think this really drives home what we do every day. One of the questions is for the people coming through those low threshold shelters, do you have a positive outlook for the future? And about 80% of the respondents said yes. So that's hope. That's building hope, which gives them the gateway to treatment services, to medical services, nutrition, on and on and on from those low thresholds. You don't have to condone the behavior, but for the harm reduction, you cannot question how it relieves the pressure on other systems within society, be it the law enforcement, medical systems, et cetera, et cetera. The other thing I wanted to bring up in Boston, a collaborative effort that has really worked for us, is the Breathe Easy at Home program, which started out to home environments of children with asthma and getting those violations corrected. We've educated the housing court on it. We've we've gotten all the healthcare in Boston to be able to directly report cases to us. It's expanded to include many more other respiratory diseases as opposed to just asthma, COPD, et cetera, and also it expanded the ages. But one of the things that I see from the inspectional part of it is we need to rebuild the trust of the community with government, with public health, with science in general, to allow us to do what we are prepared for. We have to listen to the community, what their wants are, what their needs are, and rebuild that trust in order to, help them along in the system to fulfill their needs. And I'll leave it at that.
Dr. Gabo, before I come to you, Regina, thank you for that. And it actually, I want to address an issue that's just been stated in the chat. You've talked about a number of services and programs and activities that are happening in your community, Boston. But someone has just said that our larger communities get more resources, get more involvement than our smaller communities. And this is a really important thing in our state to actually look at the disparities that actually happen across the state. And I'm wondering if we can talk about, one, let's ask, is that real? And secondly, so what do you think about it? Cheryl, I'm going to put you on the spot. Let's talk about this. You're muted.
Can you
We can hear you.
rephrase the question?
Of course. So someone has just raised this concern that larger communities get more resources than smaller communities, and that's a problem.
It
So,
is, and
yeah.
I know this person very well, and she's one of our greatest health directors in Massachusetts, as far as I'm concerned. And I think what that brings up again is the inequity in the way we deliver public health services in Massachusetts. And I think the solution to that is what the commissioner just mentioned when he talked about the opioid abatement funds and the public health excellence grant programs that now exist at the Department of Public Health. Those are opportunities where larger communities, smaller communities can collaborate together and share services and resources. And actually, MAHB is a technical assistance provider for both the opioid abatement funds and for the Public Health Excellence Grant Program. And we can help draft intermunicipal agreements where these different sized municipalities can come together and work together and share some resources that larger municipalities might have access to that smaller ones don't. And I think it's a real opportunity to pool resources so that everyone is getting the same opportunity to get fundamental public health services. And that's what Jean's talking about. That's what a lot of us are talking about. And these are opportunities now that didn't exist 10 years ago, but do now. And that's one, I think, of the strategies that can address some of the challenges that smaller municipalities are having.
Yeah, I thank you for that. I wanted to acknowledge that because I know the concerns that many people have across the state about the disparity in services and disparity in the way resources are divvied up. Sarah.
Just to touch on that a little bit, here in Worcester, we get a shared services grant or public health excellent grant. Not exactly sure of the right wording for the funding, but so we share with West Boylston, Grafton, and Shrewsbury, which are smaller communities. And so having a lot of these resources here in Worcester, I've been able to notice over the year that I've been here, the programs like community food pantries or Narcan trainings or blood pressures and things done at the senior centers expanded to these smaller communities. So I think it's definitely something, like you mentioned, we're in the direction of going and hopefully helping our neighboring community partners, even if you're not part of a shared grant. Or even if it's just a little bit of money that you get for a small amount of time. I just know that as a nurse, we always want to help people in any way, shape, or form that we can. And we were stretched beyond belief throughout COVID. So I think we are going in the right direction, but that SAFE 2.0 and a lot of this conversation and things people are doing are just the tip of everything that's needed.
Sarah, thank you for that because it's a good illustration of exactly what both Commissioner and Cheryl have actually been talking about. I'm going to do two things now. Al, I'm going to ask you please promote everyone into the stage. And at the same time, Dr. Gabo, you had your hand up a moment ago, and we may have moved past the point where, let's see what you've got. What are you thinking right now?
Now, quickly, I just wanted to say that thinking about the direction that we need to go is the first thing that I'm always thinking about is the table. So we need to know who is at the table and for what purpose. Again, as we're all talking about our desire to help people, I think it's important for all of us, wherever we are, whether as practitioners or decision-making, people, wherever we are, we need to be thinking about the table. We cannot continue to work with the same group of people and do the same thing that we used to do when things were normal while we are in a crisis situation. So things need to move or to shift, and we need to be very strategic in terms of our approach. And that's one of the reasons, for example, our community is really complaining a lot about that. We are dealing, for example, with the new, I don't call them the migrant because they're already here, with the new neighbors that we have in our midst, and coming from different communities where, the leaders are not there, the people who are serving, we are supposed to be there to understand them and to create those strategic partnerships so that we can serve them better. They are not all the time around the table. So that's one of those, I always said that we need to be creative enough to say, this is a different time. This is a change in the crisis, and this is the direction that we need to take to make sure that we can get the best, outcome for the population that we are serving.
I want to talk about table in just a sec. Al, are you able to promote our audience into this larger room?
Unfortunately, it doesn't seem to be working.
Okay.
We're trying to do it even by individuals. But what I can do is people put up their hands, I can allow them to speak.
Okay, that'd be great. So with have things that you'd like to share with us, please put up your hand and Al can promote you into this room so that you can just speak directly to us without writing into the chat, or you can write into the chat. Dr. Gabo, you raise a really important issue as we talk about this issue around collaboration, and it's a matter of who's at the table that you're collaborating with, and how do we ensure that the people who are most impacted or who are impacted in any way are at the table. Can we talk about, so what are the challenges of building the table? All of the people at this at this table have been involved in working at a table, and are people who are engaged in bringing others to the table. Can we talk a little bit about, so what are the challenges of expanding that table? And what are the things we need to think about, especially as we're talking about this business about how we need to do more around housing?
I mean, I can start. I think what
Okay.
happened is, in general, people are so used to their comfort zone, right? So, for example, let me take Natasha as an example. Let's say that Natasha has been in the field for 20 years, and for 20 years she's been working with different partners that she knows and she builds trust with, and so on and so forth. She can call them, so it's easy for Natasha to just rely on this group of people because she has built relationship with them over time. However, as things are progressing and changing and the crisis intensify, the question that Natasha needs to raise is that, are the people that I am now, at the table, are they the right people to be at the table and to bring the concern? Because what we need, and I think so many of you talk about some of the challenges around, for example, the new migrant, integration of new migrant, a car seat, for example, that is so critical for us, public health providers, is not as important for us if we are in Haiti. In Haiti, you are in a car, you hold your child, and then that's it. There is no such policy as having a car seat. So when those things are happening, there is so much for us to learn about the community that we are serving to make sure that we can deliver those services. You see, I mean, it's the same analogy that we always have, like people who are living in a hard country, it's always hard. And then you want to give them a gift. What gift do you want to give them? A coat, a fur coat. It's hard. I don't need your coat. You see what I mean? So there are so many, things that we are missing because the people who are most impacted, or the people who know best about the community, they are not there. And what it means that we need to be able to move out of our comfort zone and say, now this is not the same time. This cannot be the same group of people. Let's bring those others so that have a more fruitful conversation. Because I always said, at the end of the day, it's about the people that we are serving. For so many of us who have been in the field for so many years, I don't think that there is anything that we are really looking in terms of, building a name for ourselves or whatever. What we are looking is, how can we make an impact by serving those people in a way that is culturally appropriate and that is deemed dignifying. So once we are able to say, okay, let me move out of my comfort zone and reach out to others, then we can have better tables, because those tables are well represented. And at the end of the day, the meal that we are going to all enjoy is something that is going to be beneficial to all. So that's what I'm hoping for us to see as we are moving past this crisis.
I appreciate that very much. So I teach school, and one of the things that I say to my students often is, you need to be at the table. You need to step outside of, yes, you want to fix things and the like, but you also need to have your voice heard. You need to make certain that you are there in order to do that. So, but it's complicated in getting folks there. Regina.
Yes, thanks. I just wanted to reiterate what Dr. Gabo had said, and to build on that sometimes at the table, we are very much in our comfort zone. And as the program expands, it's hard to bring someone in who might criticize and call out what you have not done. So by not listening to the needs and the wants of the recipients, you're leaving them out of the table. Well, it's just more or less a pat on your back and not really helping the program along. I think in Massachusetts, we really need to for larger communities, we need to collaborate between the different departments, really bringing them together. But also cross-community collaboration, as has been spoken of with tackling the larger problem. We need to find out what the core problem is that brought people to the shelter and how can we address those. And sometimes it's not easy to hear critiques, but that's what the table is for. And that's, you need to get all your stakeholders there at the table participating and buying in to the actual resolution.
Regina, you've actually hit on something really very important about how complicated it is to expand the table when you are the table. That it's difficult to bring in others who may want to criticize you, who think maybe you ought to do something a little differently. And how you acknowledge that and show respect to them and maintain your table is sometimes complicated. Natasha, I'm going to come to you in just a second, but I see that Kathleen Herson has actually joined us, and I do have a question for us, or a comment, Kathleen.
Yes, first of all, thank you all very much. This is a wonderful, informative session. And being a former public health nurse, I can say that you really have so much more to balance in your careers right now, and so many more issues to address. I'm also on the board of the Public Health Museum, and we run a yearly summer course for high school students. So my question, we're trying to teach them and recruit them into public health careers. So my question is, I know there's some funding issues, but also, is there a problem recruiting professionals, particularly those that would be addressing multicultural communities?
Important question. So how broad are we? What are some of the concerns that come up around diversifying the population that we are that are working with our various constituencies? And Natasha, I have not forgotten that I see your hand there. So is it easy to hire people? Do we have enough folks? Do we need to expand our workforce? What do you think? Yeah, Sarah.
I can say from at least my perspective as a nurse, and I've got a master's in global health, and when I finally was able to focus on public health, but in undergrad school, you do 60 hours of community health in a 4-year program of nursing school. So I think there's a significant amount of people who don't know about public health or community health nursing, and we don't do a great job letting them know about it before, like, except for programs like yours and doing it at the high school level, because I know that in communities I've worked in, and I've utilized vocational students and especially the health assisting program to help at COVID clinics or blood pressure clinics or whatever it may be. They didn't even know that that was a possibility. When you hear health or you hear nursing, you immediately think bedside nursing in a hospital, in a nursing home, something like that. So I think we're missing the boat and not teaching people at age 5, wash your hands. And you know who really teaches you to wash your hands? People in public health. And start then and let people know public health is amazing really young. And I know with the Massachusetts Association of Public Health Nurses, we're really trying to expand on getting people to know about public health before they're 20 years in and then realize that it's something they want to join.
Commissioner, I want to turn to you on this question as well, because I know you have a very large workforce, and you have, and I should say for any students who are listening, their jobs at the Department of Public Health, and you ought to check them out. So there's the advertisement for you, Robbie. But you have a large workforce, and I'm wondering if you can talk both about what it means to actually bring people into the field, but also what it means to diversify that. And diversification means so many different kinds of things. I'm wondering if you address the concern that Kathy has actually raised.
Yeah, I'm happy to. So we have a huge workforce. We have 3,200 people who work at the Department of Public Health, and that spans all aspects of public health, from the folks who are working in substance use and our recovery coaches, to people who are working in our hospitals and doing frontline work, to the people who are working in our regulatory bureaus and monitoring quality and safety. And we have everyone in between that space. I will just say that it is really hard right now to bring people into public health. It's been hard for a long time. Going into the COVID pandemic, we were nationally around 80,000 public health workers in deficit in this country. We had a burst of people who came into public health during the COVID-19 pandemic, but as we are leaving the emergency phase of the pandemic, we're seeing those staff leave as well. And so we are in a huge deficit in the work need. What I think we have to think about, and this gets to the question, is that we don't just need people, we need the right people with the right skills at the right time and the right job. And to do that, we need to think about diversity and inclusion, and we need to make sure that the people working in public health represent the people that we're serving. The communities know best what they need from a public health perspective, and they should be part of the workforce that's delivering the public health. But we also have to look at ourselves and say, are we training people appropriately? Are our schools of public health training people for public health of 2024? Or are they training people for public health of 2000 or 1980 or even 1960 in some cases? I think from the department's perspective, we're trying to do some of this work. We have, through the shared services agreement and our Office of Local and Regional Health, pretty robust training program with regional training hubs. We're trying to get people the skills that they need, but that's not enough because there's a lot of skills out there that we're not training people for. It's a whole new world with how you communicate and how we can best share information. It's really a different space. And so it's important for us to continue to evolve, iterate, improve what we're doing so that when we recruit people in, which is a hard thing to do, but when we do so, we keep them highly trained, engaged in the work that they're doing, representing the communities that they came from so that we can continue to do better and better and better.
Thank you. Thank you very much. Dr. Gabo, before we come to you, Natasha had her hand up a bit ago. So you're putting your hand
That's
down?
okay. Yeah.
Okay, got it. Dr. Gabo.
No, I am so pleased to hear, this side of the conversation, especially everything that you mentioned, Commissioner Goldstein, around, being intentional. One word that I use all the times whenever we're talking about, inclusion, diversity and so on and so forth. So often we talk a lot about it, but the intention is not there, meaning that if I am very intentional about diversifying the pool of public health workers in the next 4 or 5 years, guess what? I start now. I start by going to the high school. The members of the communities are. I start inviting them to special summer public health, internship. I start to connect them so that we are really intentional about it. And I think so often we talk a lot, we see what is needed, but being intentional, meaning that taking all of the necessary steps to make it happen, so often this part is missing. And that's even, for example, as the other interview was talking about, the crisis that we are in right now. So think about our office in Mattapan Square, where every day you have this long line of people coming from all type of services, I said from A to Z. And then, for all of the public health schools in the area, yes, BU so often, reach out to us for 1 or 2 interns, or so on and so forth. But where are my public health leaders in terms of inviting the students to come and see for themselves what they will be dealing with in the next 2 or 3 years? Because once you graduate, you're going to be in the field. And right now, with the demographic shift that is happening, everyone needs to be ready for the next, 2, 3, 4, 5 years in whatever field that you are. So which means that when we're talking about representation matters, we need to make sure that we are working, not today, like 2 or 3 years ago, we are working in making sure that we have enough people to represent this group of other community members who are coming in our communities. If not, we are going to be in trouble. And I can tell you how many times I'm in meetings discussing, for example, the new immigrants who are coming in the city. How many times I'm in meeting with so many people where I'm the only Haitian Black woman in the meeting. We'll talk about a large Haitian population coming to outdoors, and so often I'm the only one. So what exactly are we doing wrong, or what can we do better? And that's the reason I'm so glad that we're talking about this, because again, this is something for us to be thinking creatively in terms of how we're going to create a new pipeline of different providers in a different field, so that those people, those children that we have here, we have so many new children in our midst right now. The educational system is should be ready for them. You see what I mean? Our pediatrician, our nurses, our school, everyone needs to be ready. They are here already. So, but if we don't do anything intentional, we're going to be talking about the same thing 4 years, 5 years down the road, and nothing is being done. And our population is going to suffer. We know that already. And then we're going to keep on repeating the same cycle. And that's the reason why, for me, the key is being intentional to make sure that we take the steps needed to make it happen. Because if we talk about it and we don't take the step, we're not going anywhere.
Dr. Gabo, that concern, that idea of thinking about being intentional is certainly critically important. In the moments that we have in our conversation, I want to do two things. I want to come first to our panelists to see if there's one last point that you want to make as we talk about what we've been talking about. And to our audience, I'm going to ask you, we were not able to promote you directly into the space, but I still want to hear from you. And I'm wondering if you will put in either the chat or in the question and answer, I want you to tell me that we're on point, or maybe that we missed the point. It's important that I get a sense about where you are as you're listening to this conversation. So first, what we've talked about. We've said housing is a right, but there are complex problems that are relating to it. We've said there are services that exist, but there's a need for more, and that they need to continue to expand as we think about what we're providing. We've also said, as we think about improving our issues that we're dealing with, that we need to be intentional in our approach, that we also need to address this issue around who sits at the table, and we need to think about the issue around pipeline as we are addressing the larger issue of how we deal with this. So I'm going to come first to our client, to our panelists, and members of the public, of the audience, if you will just write on point or miss the boat, and that'll actually give us some idea about where you are in this conversation. Who wants to start? All right, I'm a teacher. I will call on you, Natasha.
I knew that was coming. I think that this has been a really, really wonderful conversation, and I'm so glad and thankful to be part of this. I think that we've got a lot of really great folks in public health that are recognizing these pieces and that are really, truly trying to work towards all of the topics that we've discussed today in making these systems more accessible, more user-friendly. And I think, one of the points that I sort of wanted to make, I think that is so important to public health, right, is that, when you talk about community interventions and you talk about behavior change and you talk about all of these things, it's not something that happens overnight. The intentionality of this is real. And I think that what it comes down to is just this cycle of constant evaluation. It has to be part of everything that we're doing. We have to continuously go back to the table and say, who's at the table? Do we have the right players here? Do we have the right folks? And you can't be scared of acknowledging that maybe we don't. And you have to be open-minded to trying to find the right folks. And so I think that this has been a really great conversation. And I think that I personally in public health, through lots of different organizations, through Charles' work at MAHB, through MHOA, through MMA, through all of these different organizations, MIHA, I'm seeing that shift in local public health. And I think that is really, really just a wonderful thing. And I think that we've got a lot of support from the state. And I think, the local regional health office has been a wonderful addition. And I think we're going to continue to move in that direction. And I'm just so excited to see where the future
takes
Thank
us.
you. I'm going to come to each one of you, but I just want to let folks know that we're at the end of our allotted time, but I'm going to take it over just because I can, and so I can hear from everyone. Who's next? Remember, I will call on you.
Be to jump in.
Okay.
Also, because I apologize that I have an 11:30 that I have to get to, so I'm going to have to drop. But maybe the one thing I'll just add to the discussion that we've had, which I think has been fantastic, is that I think what we're all speaking about is a health in all policies approach. The importance of keeping health central to what we do, whether it be we're talking about housing, we're talking about our immigration policy, we're talking about our economic development. We have to keep health central to that because health is a right. Having access to healthcare, having access to the social determinants of health, and that's I think where this conversation for me has been heading. So and with that, I will say thank you to everyone. And I apologize that I need to drop.
Thank you, Commissioner. Who's next?
I can
Sarah.
go.
Sarah. I see Sarah's hand, and then Cheryl.
I was gonna say, I'll let Cheryl go, but I just wanna point out and agree with the two things that Jean said in the question and answer with public health needs to be fully funded because it does make things a little difficult when we are searching and finding our community partners to pay for things that we can't pay for, or retaining great employees because they're not the most paid or valued. And I don't know a great way to put it, but yes, we need more money. And then when it comes to boots on the ground and where I want to go with it is we don't know what people need. We can assume what people need, but we all know you shouldn't assume things. So we need to get into these communities. We need to go and speak to the people who are most impacted and most influenced by whether it's our new policies, this, that, or whatever, and make sure we are trying to solve the problems not only that we see, but that they feel that they need solved, because they won't feel listened and they won't cooperate, and we won't know what is needed if we don't actually get there and talk to people. So thank you, Jean, for saying that and giving
Thank you,
me
Sarah. Cheryl?
I just want to underscore the opportunity that we have now to collaborate with other municipalities, which is something that public health has not done in a very long time. And I just hope that we continue the vein in which we're going and that we pass Safe 2.0 so that we're able to continue the work that we're doing collaboratively, because I think it's going to make a huge difference in lifting everybody's boat so everyone in Massachusetts is exposed to the same level of public health services.
Yeah. Thank you, Cheryl. Regina.
Thank you, Harold. You know, this was only an hour and a half. The topic, this could have gone on for 4 or 5 hours. There's just so many things to cover in public health when it comes to housing. But what the takeaway I want to put out there is that it's very crucial for us to maintain a public health workforce and grow that public health workforce so that we have we have the institutional knowledge passed down for the lessons that we learned out of the pandemic and any other crisis, that those get carried over so we're not constantly starting anew with the next crisis, the next pandemic, et cetera. We need to have that workforce ready and able to pick up and continue on.
Thank you. Dr. Gabo.
Thank you again. Very important conversation that we need to continue. And again, for me, I always think about the village model where we say it takes a village, right? And even in the housing crisis, we need that village approach where all of us, we are playing our role, and all of us, we are, again, being intentional about including those who are impacted by the crisis to be part of the decision-making process, not just a receiver at the other end, but being fully participate in whatever decision that is being made. And that's how we get the most results. So we need to rethink our approach in terms of, reaching out to the people by not having to translate, because I always said, every time that you need a translator, you are losing 50% of the essence of the conversation. So as long as we can bring, those who are impacted at the table and get them involved, I think we're going to go very, very far.
I'm so grateful that all of you have joined this conversation. Dr. Al, I want to invite you to come back and see if you have any last words for us, but I want to thank our panelists for an informative conversation. You've certainly helped us to dig deep, and we have so much more to do. Thank you very much for your participation. Dr. Al.
Yes, thank you. Thank you so much for a wonderful discussion. It's thought-provoking, informative, and covered much territory, and clearly could have gone on covering more. It has been recorded. It will be on the Public Health Museum website. So we greatly appreciate that. And noticing one comment from Alice Moore, as a member of the public, not a healthcare professional, I am so impressed by every member of the panel. Makes me proud to live in this state. Not perfect, but I see people who really care. Also, kudos to the moderator. Excellent job. Skill of the moderator makes or breaks these things. And that's the key reason why we always ask Harold to do this, moderating. So thank you all. The bad news is that we couldn't figure out how to get people into the room from the attendees. The good news is we figured out why that was, and maybe can do better next time. And the final thing I want to say is there actually was an earthquake. It was centered in northern New Jersey. And I think that's what was felt by some of the panelists. So thank you all once again. Thank you to people who attended, and best wishes for a happy Public Health Week.
Thank you, everybody. Bye-bye.